Thank you, Selena, for recording the lecture today. It will be available on the SMCI website along with the slides that will be presented today. Quick announcement, in addition to Lisa Freeman recently had a birthday. Happy birthday, Lisa. We also want to put on everyone's calendar that the Stanford Lean Conference will be October 4th and 5th of this year. And I believe abstracts are due soon. Maybe more information will be in the chat. Lisa, could you put the deadline in the chat, please? But for today, I am pleased to welcome Dr. Caroline Park, who won the best publication, improvement publication, authored by a first author trainee. This was presented by SMCI earlier this year. Dr. Park received her MBA and PhD degrees at Albert Einstein College of Medicine, and then did an internal medicine residency at Icahn School of Medicine at Mount Sinai in New York City. She also completed her clinical geriatrics fellowship training at Stanford School of Medicine, and currently she is in her second year of advanced geriatric medicine fellowship at VA Palo Alto. She is mentored by Dr. Ann Chang, Dr. Deborah Cotto, and Dr. Michael Snyder. Today, she will be presenting her award-winning work on a geriatric trauma clinical pathway and changes in the rates of delirium in older adults with traumatic injury. This work was mentored by Dr. Matthew Messias and Dr. Christian Stoudemire. And again, we are pleased that Dr. Park is the first recipient of the first authored by a trainee improvement publication award. And thank you all for coming. And I will hand it over to you, Dr. Park.
Okay, great. Thank you. Hold on one second. Okay, can you all see my screen?
Yes, that looks great.
Okay, very good. So thank you so much for that introduction. And it's really an honor to be this award recipient as a trainee. And just want to put the disclaimer out there that this was not my own effort, but really a whole team of individuals who came together way before I joined the team for this to happen. And so want to just put that out there first, that we thank everyone who was involved in this project. And again, I'm really thankful to be here today and very honored. So thank you very much for your time and attention. So today I will tell you a little bit about our Stanford Geriatric Trauma Care Pathway that's really been developed over the last, I would say, 7 years or so. And I was a geriatrics fellow starting year 2020, right at the hit of the beginning of COVID, and was fortunate enough to witness some of these dramatic changes over the last few years of really implementing this fabulous pathway in the Stanford system to improve outcomes. So this was our paper that was just published last year in June of 2022 in JAMA Surgery, titled Association Between Implementation of a Geriatric Trauma Clinical Pathway and Changes in Rates of Delirium in Older Adults with Traumatic Injury. So want to just, before we go forward, introduce the author team. And we've had a total of 10 authors and a number of other individuals who are not on the author list, but have made this project become possible and a reality. So want to just thank everyone who was involved in the project, as well as especially my mentors, Dr. Macias and Stoudemire, and Dr. Berija, who's not here anymore, but was an integral part of this project as well. So I want to just tell you a little bit about, of course, the burden of geriatric trauma, which is a national problem. And there is this need for improvement in clinical outcomes because, as we know, our US population is rapidly aging, and it's projected to be about 95 million by the year 2060, which by that time it would become 23% of our total population. And especially the trauma patients over age 65 are estimated to be almost about half by 2050, which is really remarkable. And traumatic injury in older age above 65 years is associated, of course, with worse outcomes compared to our younger individuals. And work in the past has really shown that a multidisciplinary approach to frail older adults with trauma resulted in reduction in delirium and 30-day readmission rates. And this was work done out in Boston. Additionally, for the geriatric trauma burden here at Stanford Healthcare, we have seen an increase in trauma admissions, for example, from the year 2017 to 2018, about a 24% increase. And approximately half of those trauma admissions were in individuals older than 65. And most of the time, these trauma patients who are older happen to have time-consuming, but usually non-operative problems. And because of that, they also tend to be usually under-triaged. And the most common mechanism of injury here at Stanford in our older adults was tending to be ground level falls. Additionally, what we worry about is these high rates of ICU quote unquote bounce backs and complications, which include mortality, morbidity, other complications, delirium, and worsening functional status in these older adults that really worry us more as geriatricians. And then all of this, of course, amounts to higher direct cost of care. And we also know that these margins on the geriatric population is quite narrow, and that the gains over the loss for older versus a younger population might be $800,000 for those who are 65 and older, compared to $35 million for those who are younger than 65. So we really are in this marginalized, very vulnerable population, and really have to get it right, so to speak. So we had this objective of developing this multidisciplinary trauma care pathway for our older adults, incorporating specifically age-friendly health systems initiative, with the overall goal of value improvement, change in culture, and also advance in equity. And I am very proud to relay this information that our Stanford Healthcare, Stanford Senior Care was nationally recognized by the Institute for Healthcare Improvement for geriatric trauma work, specifically in 2019. And this was the highest level of recognition for becoming an age-friendly health systems program. And it really demonstrates our ability to deliver very highly age-friendly care consistently and reliably for at least a minimum of 6 months. And because the IHI was still impressed with our outcome measurement dashboard and our process, they've really selected us as one of the 18 institutions among 200 plus participants to be allowed for a 18-month extended period to really help us analyze more of our geriatric trauma cohort in this aspect. So what is the age-friendly healthcare system? How many, just for a show of hands, I'm not sure of from the prior talks if anyone has mentioned this, how many people in the audience can I see are familiar with the age-friendly healthcare systems and the 4 M's? Can I see a show of hands? I see not too many. Let me see the gal. Okay, I see 1, 2, 3. Okay, very good from the geriatrics team. Thank you. Yeah. So the integrating the age-friendly care system, really the 4 M's movement, sometimes is a 5 M's, constitutes with the 4 M's, the letter 4 M's really, which is medications, mentation, mobility, and what matters most. And the whole initiative is really to include these 4 elements of age-friendly care as best as we can in multiple care settings for our older adults. And here at Stanford, we were interested in implementing this age-friendly care in specifically, as you know, our geriatric trauma cohort in the non-operative management. And it goes actually in phases. The pathway was developed in such a way that this is our protocol starting from phase A, where we do receive the patients in the emergency room to the first 24 hours after admission, and then to the recovery phase, where it includes this, you can see it's color coded here, with pain control and other measures that are important for recovery. And then closer to discharge, we have these discharge milestones that include early mobility, pulmonary toilet, and other things that I'll be talking about later on that are part of this discharge milestones, and then to ultimately reach our post-discharge phase, where we will be safely discharging the patient. So there are several of these milestones each along each of these steps of the pathway. And the age-friendly health care systems forum's care definition specifically for our Stanford team was, for example, for what matters most, we would ask what's most important to you during this hospital stay, and to identify a healthcare proxy, or if not, surrogate decision maker, and then also look for a previous advance directive. And the frequency would be once per stay, and for all and recurrent if were needed. And then the measure would be percent receiving goals of care. And this went into our paper as well as a metric. And then, for example, for medications, we would screen their home current medication list, and then also screen for potentially inappropriate medications that are likely to be harmful for the individuals in case of our older adults, and this would be checked daily. And our measure would be to screen this medication list on admission and do a medrec specifically within 48 hours of their admission. So we do this very, very quickly to prevent adverse reactions from potentially inappropriate medications as well. And then for mentation, we do this screen by Delirium with the confusion assessment method that is implemented by nursing staff, and this is done every shift. And then we counted the percent positive CAM score, which is positive for delirium, in the chart, and we would look at this as a metric as well. And then for mobility, we screen for mobility, and then the time to ambulation and how long it took really for them to do that, starting admission, and looking at that daily. And then as our metric, a number of hours or time that passed to first mobility from the time of admission. And we know how important that is to try to mobilize our older adults as soon as possible when it's safe to do so. Additionally, when we analyze or when we implement our age-friendly care, we also take into account all of these geriatric, what we call quote unquote spices. And that includes sleep issues, pain and polypharmacy, issues with immobility, if there is any confusion or constipation, their nutritional status, and then any other social support or sensory impairment issues. And specifics are listed over here with the template here of the questions that are being asked for each category. And so you can already see at this point, even without having gone through the explanation of what we found, was that this is a tremendous amount of work that needs to be placed in order for one patient to receive, quote unquote, the simplified 4M's age-friendly healthcare systems care in specifically someone who's experienced trauma. So this is once again showing how difficult and challenging it is to really bring this to life. And so the first initiatives really, as I was telling you about, started in 2016 with very targeted geriatric trauma consults, which then developed into geriatric trauma specific order sets in 2017. There was a pilot ACE unit on 300P on C2 in 2017, but that was not sufficient. So hence we created the geriatric trauma care pathway in 2018, which then led to development of our geriatric ED in 2019. We won recognition for age-friendly health systems in 2019. And then finally, the grand opening of our ACE unit, acute care for the elderly unit in 500P in the new hospital in January of 2021. And really the initiatives that started back in 2016 started with a Geri Trauma 65 screen, just looking to see if we can screen out very high risk individuals by the trauma service at 24 hours during the tertiary survey. And during that time, what they found was that the team was consulted in 90% plus cases appropriately, but there was a very high rate of delirium. 23% of the consults had this, and 50% of them had cognitive impairment, and 70% of these individuals also had medication change recommendations. And so there was room for improvement for us to engage the nursing staff, as well as make changes to our order sets to better help our care of the older adults with trauma. And then you can see here with the timeline that in May 2017, development of the order sets, and as I elaborated a little bit earlier, in October 2017, this nursing-driven screen incorporating the geriatric spices format, and also bringing in our APP staff to take a bigger role in this IDT. And then finally in 2018 of November, we really started to build on this and make this multidisciplinary, including our nursing staff, rehab, social work, care managers, and the trauma team, as well as the geriatric medicine team. And then looking at all patients who are 65 plus who are admitted under trauma service, instead of just doing a targeted geriatric consult that is provider driven. And so here is an image of, most of the authors are actually on here in this image. This was predating my time. Here's Dr. Stoudemire, Dr. Macias, Dr. Marina Martin, who is a former chair, section chief. And here's Purnima, Ann Mitchell, Amy Liu, Alyssa Nolf Brown. And then these two individuals, I'm not sure, I don't recognize, but these are all part of this very multidisciplinary steering committee that helped bring this project to life and to this stage. So we used this design process really to do state process mapping that included the patient continuum from starting from ED through the discharge, and then identifying barriers to consistency in care. And then additionally, this included order sets, automatic multidisciplinary consults that include our colleagues in PT, OT, nutrition, case management, as well as implementation of documentation requirements of, for example, goals of care, documentation of first time to mobility, as well as algorithms to escalate care when needed, and triggers and reminders about how to manage expected and common symptoms such as pain management, bowel management, and sleep regulation in specifically our older adults. And then there was a multidisciplinary team meeting done daily during the week on the non-ICU trauma unit with a geriatrician. And then prior to discharge, there was a transitional care team consulted if it was appropriate. And those presenting with the ground level fall as a cause of injury, they were provided also with patient education materials, such as fall prevention materials, as well as referral to Farewells to Falls program. And this is just an example of our geriatric care pathway dashboard. And you can see over time, this is updated monthly in the volume and average length of stay coming down here. The number of hours to first mobility at first glance also seems to be decreasing. Our delirium score here seems to be a little bit lower in this case, and average number of hours to goals of care note, despite this blip, is overall trending downwards. And I'm sure that there is additional data that we can look at for more updated years. For example, this year, I'm not sure what the data looks like just yet, but these are some of the outcome metrics that we are continuously monitoring as part of the geriatric trauma care pathway that was established and ongoing. And for those of you who might be interested in this pathway, it is available to be viewed under EPIC. In the tools under the care path link, there is a geriatric non-surgical pathway. And in terms of order sets, if you're curious about this, the order sets are updated in the inpatient surgical general admit list, as well as the general ICU inpatient rib fracture protocol. And so those are some of the examples you can look at. And here is just a few screenshots of the examples of what you would find there within the standardized EPIC documentation set. For example, scoring pain level, their mobility status, their pulmonary toilet status, and their sleep pattern, as well, and a number of other examples of what's included in the order set as well, according to the geriatric spices. So that brings us now to the clinical question. We had an objective. What is the question? The question is then the establishment of this geriatric-centered clinical pathway associated with any improved outcomes for injured older adults, knowing what we talked about just now. So our study design was a retrospective case control study between 2018 and 2020 here at Stanford University Hospital in our injured older adults of age 65 and above who were admitted to the trauma service but received non-operative treatment. And we specifically excluded patients who were undergoing the operative treatment pathway. And then the intervention was really to implement this geriatric multidisciplinary pathway, clinical pathway for care, and looking specifically at primary outcomes of delirium and mortality as well, but I'll talk about this a little bit later, that we didn't see statistically significant improvement in mortality because of small numbers. But our primary outcomes really were delirium and mortality, and secondarily looking at hospital length of stay as well as other process measures. So the key elements, which we know about of the 4 M's, the medications, what matters most, mentation, and mobility, we built upon that here at Stanford, including discharge planning, the nutritional status, pain, bowel, bladder, and then really looking at this as a whole, moving all together. And this involved, of course, this multidisciplinary team of everyone involved, but especially in the center, the patient and caregiver. And this, I wanted to stress this, that we really did make an effort to incorporate the patient and the caregivers and view this pathway as part of a geriatric-centered, patient-centered pathway, as multidisciplinary as it is. And the analysis was done between starting from September 2015 all the way through January 2020. And again, we excluded patients who were undergoing the surgical pathway because we were specifically interested in these individuals who were undergoing the non-operative pathway, and was the majority actually of patients who were coming in with ground level falls with trauma. And here is the baseline characteristics. We really did not see much difference in terms of the sex, although it was slightly skewed towards being more female. Mean age was 81 in the baseline group, and then about 81.6, also not different in the post-implementation group. Here are the age categories, which you can see, which is widespread between 65 to 90 and roughly equal in proportion. And then race and ethnicity wise, we did have a skew specifically towards Caucasian individuals, and the next majority was Asian, and then we had some other racial ethnic groups as well. In terms of their language, most of them were English speaking, and the mechanism of injury really was mostly with fall, although we had some other injury mechanisms like bicycle accidents, motor vehicle accidents, and then other or sometimes missing data. This is injury severity score, which goes from low, intermediate to very high. And you can see that the majority was less than 15, which is the low to intermediate injury severity score risk. So when we first look at the unadjusted clinical outcomes at delirium and length of stay, you'll see here that the delirium and the length of stay was statistically significantly improved here post-implementation, as well as the length of stay, even though not statistically significant, there was a trend towards improvement. And also that in the post-implementation group, we also saw a significant proportion of patients who are in the minority injury group, or ISS less than 15. The question though is, what about mortality? And this is a result that that we did not include in our published data because the cell size was too small. But when we did look at it, actually initially when we submitted the paper, we did see an improvement in mortality in a statistically significant manner, specifically in those with relatively minor injuries. And when we look now at the adjusted data, looking at adjusting for demographics and also injury characteristics and the logistic regression, we also saw a significant improvement in delirium rate as well as mortality, but not so much in length of stay. And when we look at now this effect by subgroup analysis by cohort, what we found was specifically that in female individuals, as well as those that came in with a fall in mechanism of injury, and those with a relatively milder injury severity score, is those individuals that tended to benefit from a greater reduction in delirium in a statistically significant manner. And I also want to add that we did not publish this result, but when we do the subgroup analysis specifically for also English-speaking individuals versus not, we saw a greater reduction in those who did speak English, which we'll talk about a little bit later in terms of what that might mean for our future work. Now looking at process metric outcomes, you'll see that for the pain control scores for the first 24 hours of a pain score being documented versus pain score of 4 or higher, we'll see in both categories that there's a statistically significant pain score documentation and also higher pain score post-implementation. And this might be because of greater documentation overall or screening better for pain after this pathway was implemented, but there may be other reasons why that requires future work as well about why this might be. Additionally, and importantly for our 4Ms care, you'll see that our goals of care, if the length of stay was greater than 2 days, both number one, the presence of documenting that this goals of care discussion happened, and also the time to the first discussion of goals of care has significantly improved in our post-implementation group in a statistically significant manner. And in terms of quality improvement for this SMCI audience, I think it's quite important to note that across the board, this is with time of all patients versus patients who are coming in as elderly or older adults with trauma versus other adults who are coming in for various reasons under the trauma service. You can see actually that the older adults improving in their major hospital events rate, actually the risk, actually contribute to the overall improvement and reduction of adverse events. And so we did, the older adults, we think the geriatric trauma pathway being implemented a little bit contributed to the overall improvement in quality in terms of the trauma service outcomes. And here is a chart that was generated by Dr. Stoudemire, my mentor, looking over time at the relative reduction in risk of delirium in our positive CAM cohorts. And you can see, with time really starting at implementation in roughly about 2018 here, you can see this reduction in delirium rate as well. So in summary, I would like to conclude and say that this Stanford Geriatric Trauma Care Pathway reduced specifically delirium and to some degree mortality in our injured older adults, and the benefits were most significant in those with minor injuries. And this reduction in rate of delirium were common after you adjust for baseline demographics, but also there was some sex-specific effect as well as a primary language effect where females as well as those who spoke English benefited more from this reduction in delirium, which points to areas that require closer attention in the future. And the pain scores were higher in the post-implementation period, and we're not entirely sure why this may be, but it may reflect changes in how the pain was assessed after this pathway was implemented. And this I already spoke about, so I will skip this. Additionally, this was our first, this was actually nationally the first study to implement this age-friendly 4Ms healthcare system towards a older adult trauma pathway. And the novelty really lies in the wide breadth of elements that we did include, which points to the challenge of bringing something like this to life is so difficult, I think, which is that the wide breadth of elements include this multidisciplinary team, as well as patient education, improvement in our order sets and technology, early pain management and mobilization, and active engagement of both the patient and the caregiver, as well as multiple services in the management of the care of these older adults with trauma. And that we were actually very inclusive of older adults who are above the age of 65, instead of cherry picking those who are at high risk, for example, those who might have a frailty score of greater than 3, for example. And these findings, luckily, are actually consistent with previous reports showing that it is very beneficial to implement a geriatric-friendly care in a focused interdisciplinary team manner to bring about improved outcomes in our older adults with trauma. And also that we saw mortality and delirium benefits that are most significant for those with minor injuries. One of our limitations, of course, is that our population was skewed towards mainly Caucasian and English-speaking patients. And so this is an area where we need to expand our studies to see whether the same thing might be true. And so ultimately, in our future directions, we would like to see this be expanded to other care pathway settings across the nation. And hopefully we can start with like a regional extension of other hospitals that are not at Stanford, but perhaps in the Bay Area that are nearby, and we can test this. But our hope is that we have provided enough of a model care system that shows that it is indeed possible to do this daunting thing, to incorporate everyone as much as possible in this idealistic situation of providing the best age-friendly care that we can to our older adults who are coming in with trauma. These are our references cited, and I really would like to thank the SMCI team and members of the committee for selecting this paper for this award and for this time, this precious time of sharing our work with you. Also the Stanford Healthcare High Value Care team members, our entire author team, once again, and especially my mentors, Dr. Staudenmeyer, Macias, and Dr. Berija. So with that, I'm very happy to take any questions. I haven't had a chance to look at the chat just yet, but I will stop share and look at the chat, and feel free to.
And we can call out on people to ask their
Sure.
questions.
Yeah.
A great presentation. Thank you, Caroline. I think we'll start with our first question from Steve Ash. If you could come off mute, Steve, otherwise I'll ask your question.
I can come off mute. Carolyn, it's good to see you, and what a great study. You should be so proud of yourself. I really hope you are. So I'm always interested in the details of the evaluation.
Oh, can you hear Steve? Caroline, can you hear Steve?
Okay.
Are you not able to hear me?
Oh.
Hold on a second. Hold on 1 second. Let me leave and come back, because
Okay.
like it's my problem. All of a sudden I can't hear anybody.
Oh, no.
Okay. I'll be right.
Okay. Well, thank you for your patience.
Okay. Hello?
Hello, can you
someone
hear
say
us
something?
now?
Can you hear me?
Interesting. I cannot hear. Hold on. Let me see if I can do it.
Can you hear us now?
Okay. Yes, I can hear you.
Okay,
Yes.
awesome.
Yes. Okay. Yeah,
Okay.
okay. Great. Okay. Yeah.
Great.
Sorry. Yeah. Steve. Yeah. Dr. Ash, go ahead. Yeah.
Carolyn, I was just saying what a great study, and you should be so proud. I hope you're very, very proud of this really important work, incredible work. I'm always really interested in the details of evaluation, and that's what I want to
Yeah.
ask you about. So I believe that you show a great pre-post difference, and what I want to do is help you defend against people who would say that there's a problem with pre-post studies. There's always a problem with pre-post. So one of the possibilities is that people are just less sick in the post period. I can see that the ISS is the same, more or less. What about other comorbidities?
Yeah, that's a great question. And that's actually one comment that we received from our reviewers in the beginning about how come you didn't look at comorbidities versus frailty status. And this was predating my time before I came in, but I believe that Dr. Stoudemire actually already looked at this and said that there were not significant differences between those who had more comorbidities or less. And one reason might be because when you are coming in with number one, AFOL, and are admitted and are sick enough to be admitted, that by definition probably qualifies you for being frail or maybe pre-frail, and also that you might be expected to have a number of comorbidities as well. And so that's sort of one of our ideas about, or the defense mechanisms for how we might answer that question, but specifics of when we which sort of comorbidities we looked at, I'm not sure, and I'm not sure if Matt knows better about the details about what comorbidities specifically we screened for, but I do believe that for the baseline data collection, it was all put together, and we did not see a difference. And that's one of the distinguishing factors actually that we sort of pitched when we were writing the paper compared to the other group, Dr. Zara Cooper's group, who is out in Boston, who looked at implementation of a geriatric trauma pathway such as ours, but specifically in those individuals who are subselective for frailty. And our study's strength, I think, is that we included everyone and not just have selected those who are already at high risk. I'm not sure if that answers your question, but Matt, yeah, feel free to jump in if you have anything else. Yeah.
Thanks, Carol, and fantastic work as always. Sorry, I don't have the answer to that off the top of my head. We'll have to dig into that because I'm not sure why we didn't include that in the original paper, but thanks for that question. And congratulations again, Caroline.
Oh, thank you. Thank you.
I see the next question in the chat is from Hannah Kirsch. If you're able to come off mute, that would be great.
Oh, sorry, because I left and came back, I can't see the chat history. Could you repeat the question? Yeah.
Yeah, so I don't see Hannah popping off mute, so I'll ask the question. Hannah would be interested in hearing about the ICU versus non-ICU patients with the same level of injury. Was the ICU a risk factor for delirium, and how did it benefit those patients?
Oh, great question. I actually don't know off the top of my head. I'm going to have to dig into the original Excel sheet about whether there was a difference between ICU patients versus not. That was not included in our subgroup analysis. So, but great future analysis plan. Actually, we will include that in the next run.
Thank you. Deb Denham, would you be able to ask your question?
Awesome. Yeah. It says, because my patients are protocolized to come to ICU, even if they don't have high needs. Yeah, absolutely. Yeah, for sure. One other way to avoid ICU, right?
Yeah. My question had to do, was there any way of knowing pre-trauma what their mentation status was? Because once you're talking about some of the elderly, could early dementia have affected their delirium later on?
Yeah.
I guess it's kind of the same as Dr. Ash's question about
absolutely. Right. Super important, right? Baseline mental status and baseline functional status is really, really important, but we didn't do the subgroup analysis to look at, to separate actually based on their baseline cognitive impairment assessment. So that's one thing that we can include in our next round of studies, or improving our existing trauma care pathway to do a quick screen, maybe just even a mini cog or something to screen for dementia in the beginning. Yeah, thank you for the suggestion.
I had one other quick question. on the race and ethnicity for this group. Was it
Sure.
similar to what the overall admission for Stanford is? Because I would anticipate that their overall
Yeah.
would be, yeah.
Yeah, I can't speak to the ones that are outside this jury trauma pathway, but I would assume, based on my limited experience at Stanford on the inpatient side, based on my anecdotal observation, seems probably pretty skewed towards Caucasian individuals and maybe some Asian. But I'm not sure if anybody else in the audience has concrete numbers or had seen it otherwise. And that's actually one of the reasons why we want to expand this study to include other hospitals in the area that perhaps may not be as skewed towards a certain racial ethnic group. And we do
Right.
want to study, diverse populations.
Yeah, I think that'd be especially important in this. Yeah.
Absolutely, I agree. Yeah. So Purnima, one of our authors, said we should have that data from our trauma registry. Yeah, so great point. I am writing all of these future ideas down because that's going to be our next project. Yeah, go ahead, Chris.
Excellent. Thank you.
Yeah, thank you.
Hi, Caroline. Thanks for this presentation. Really great work.
Thank you.
So a question I have for you to look at is to look at the post-discharge destinations of the individuals in your study. So for those of you who went to the Department of Medicine meeting yesterday, it was all about discharge destination and trying to get the hospital unclogged, basically. And so I think if you can prove by, we decreased delirium or people went home, you'll get a lot of buy-in from the hospital system to advocate for such interventions.
Agree. Yeah, thank you so much for that. Yeah, I think it's been a while since I looked at the data, but there was actually, let me see if I can pull up the raw data here. I did look at discharge destination, hospice versus return to ED versus mortality. That actually data was not significant, but it may be because I didn't use the right statistics to analyze it, but yeah, thank you for that point. Great future project continuation. Yeah.
I'll say one thing. It doesn't have to be statistic. It doesn't have to be statistically significant. You free up 5 beds, they're happy.
Oh, I see. Okay, awesome. Okay, got it. Thank you.
Marcy Winjet had a question in the chat. Would you like to come off mute, Marcy?
Sure. Hi, Carolyn. That was such a great presentation, great project. I was wondering, what advice or kind of learning nuggets do you have that to give to others that you just feel like were kind of key things that made this successful that you would definitely do again and you would definitely strongly advise others to do?
I think I am. Thank you so much for that wonderful question. I think I am way too junior to comment on that. I'm going to defer to Dr. Macias on that because I really was a late writer on this and was the most minor person in the team. So for this daunting project to really come to life, which I still can't believe it has been implemented, but I think that really the team members have done such a great job. And number one, staying on top of communication. And then everyone was so driven to do this together to help our older adults. And I think that motivation, individual professional motivation, being there helped a lot. But I'm going to ask Dr. Macias to comment on the rest of how this came together and to answer your question better.
Thanks, Caroline. Yeah, some of this predates me too. But we had a lot of buy-in from our surgical colleagues, and Kristen Sotomayer's team really bought into what we're selling from the age-friendly work. And then I think a lot of multidisciplinary support from the different team members, case management, pharmacy, PT and OT, spiritual care, social work. Everybody was on board and felt like this was a need and really believed in the work. And I think that's hard to do. I mean, that's not easy. It's not an easy sell because there's a lot of unpaid time and effort. And then I think from a practical perspective, sometimes you have to do the work, and a lot of this work was, people doing more work, and so more OT consults and more PT consults. Selling that, I think, is in some ways hard when everyone's overstaffed. And then, frankly, more geriatric consults. So our clinical teams stepped up to do that too. So there's not other than getting folks to buy in, I think is easier said than done, and I didn't have to do a lot of that work. But I think having that shared mission was really important. In doing this and continuing the work forward as we continue this geriatric trauma work post this implementation.
Thank you, Matt. I also want to just go back to Chris's question and comment that I was able to find one piece of raw data that I do want to share with you all, which is part of our improvement looking from 2017 all the way through early 2020 when this analysis was done. We had some improvement in our 30-day readmission rate going down and also our return to ED. Not so much, I think, in the direct cost per patient. I'm not sure for that, but perhaps maybe a slight decrease in the length of stay, but definite decrease in our delirium incidence, which is what we saw in our study cohort as well. And then when we looked at the discharge destinations here, you can see that the majority who were admitted with trauma, who did not undergo surgery, were either home or to a skilled nursing facility. And the length of stay is around 4 days or so. And that was like shortened by like 0.1 days. So we're still a ways away, I think, from making that large leap in terms of hastening discharge. But hopefully now that we've had this official pathway running starting 2018, and now it's been like 5 years, and we have all of your input to make this pathway even better, I'm very hopeful and optimistic that the numbers will continue to improve. Yeah. Any other comments, questions, new ideas for the future studies?
I think Ting
really-
Hun had a suggestion for an outcome. Ting, would you like to come off mute?
Yeah, because most of the patients are coming to hospital because of fall. So do you have any measure or any data on, say, after discharge 3 months, or say another fall or something?
Sorry, I missed the first part. Can you say that one more time?
Oh, because most patients actually come to the hospital because of a fall, right? So
Yes.
the fall, right? Because so after 3 months discharge, did you or any time period you measure whether they have another fall?
Yeah, great idea. So at least indirectly, what we can tell is that we have made a difference in terms of coming back to the ER or being readmitted within the next 90 days post-discharge. But in terms of looking at all of them following, I'm not sure if we have that comprehensive data set. But great point. Of course, yeah, whoever's coming in with a fall is already going to be at risk for another fall for sure. Yeah. So yeah, thank you for that idea and suggestion.
Carolyn, I'm sorry, can I ask you another question?
Sure, go ahead, yeah.
Yeah, if you're looking at length of time and you're talking about the geriatric patient, for them to be admitted, there has to be some kind of anticipation that they're going to be there a certain number of days.
Right.
So you're looking at reducing length of stay. Is it realistic to think that you're going to dramatically decrease that? Do you see what I mean?
Right.
For them to even be admitted, you have to anticipate they're probably going to be, if you use 2 days as could we get them out in less than 4 days? But we anticipate not more than,
Right.
Yeah.
Yeah, great point. Excellent. Yeah, that's true. You're right. Yeah, I mean, everyone had to have stayed for at least a minimum of 2 days. And so the question is, can we now shorten the average length of stay from 4 to 3? That's a huge improvement. But you're right. But you're right. I mean, by default, because it is an older adult who's over 65 who's coming in with trauma, the likelihood of them staying less than 2 days is like probably 0.
Yeah.
So yeah.
But less than 4 would still give Chris some more beds. So.
Right. exactly. Yeah, thank you.
Caroline, I have one more comment in terms of
Yeah,
length of stay. You also
Yeah.
have to think about, I think your data is from 2017. So there's the
Yeah.
3 midnight rule for to be admitted to a SNF. So
Mm-hmm.
that's going to affect your numbers. So I wouldn't
Right.
focus really so much on length of stay,
Okay.
but rather like where they go. Now people can be discharged faster because I think that I think Stanford now has a Medicare waiver, but just keep in mind that's like interfering with your numbers.
Sure. Right. Good point. Thank you, Chris. Okay. Wow, great. So many great ideas for follow-up study. I gained a lot from this actually. I think the gain versus time to put into presentation is like way it benefits way more. So thank you all for your great critical input. Basically, it's second grade was written, I think.
Yes, thank you, Caroline, for
you.
presenting. We're over time, but any other last comments from the audience?
I do want to just read some of what our co-authors have pointed out, which is that Anne wrote that length of stay and readmissions are hot topics. Currently, we can consider going forward and would love to broaden to non-English and become more inclusive. Yeah. And yeah, ways to get this to work. Purnima says, have a good key stakeholder buy-in. And also, we did a lot of data analysis prior to designing the pathway. That is true. This is all predating my time. And to identify the right cohort and key outcome metrics, the team makes it. And then Alyssa says also frequent meetings and check-ins, communication, and key stakeholder and buy-in, like Purnima mentioned.
Awesome advice. So I think to give everyone time to prepare for their probably 1 o'clock meeting, I'll make a final announcement. So again, thank you, Caroline, and your team for coming today, giving us great insight and presenting this great work. Our next SMCI lecture is going to be June 27th, same time. And we're going to have Dr. Candace Tompkins from the ACR Network Learning Collaborative talk about their first round of implementations with our radiology project. So our radiology department. So excited to hear about that. Thank you once again to the team that presented today, and I hope you all have a great day.
Thank you.
Thank you.